So what after medical treatment for adult glaucoma? Not everybody has access to SLT in the form of laser therapy. Not everybody requires SLT. So most of the patients that come to us come at a stage when when the drugs stop working, they require a trabeculectomy. Now, how to do a trabeculectomy is something that you would have seen in videos or with your consultants. How the trabeculectomy survives is based upon what we see before and how we nurture it in the postoperative period. So that's why I chose before and after trabeculectomy. Now, in an ideal scenario, an ideal patient for trabeculectomy, for it to work, would be somebody who's over 40, phakic, with an uninflamed eye, and with no prior history of previous intraocular surgery. But such perfect patients are very hard to find, and therefore, for the rest, we have to find out things in the pre-op scenario so that we can counsel them and we can also modulate our own treatment, our own pre-op regime. So general health is often ignored by ophthalmologists. We are so focused on the part that we are subspecialists in. So we many a times don't focus on the intraoperative and postoperative modulating factors like blood pressure. So uncontrolled high blood pressure, tachycardic patient, or patients with bleeding disorders or pre-existing arteriosclerosis can have a compromised blood pressure profile, in which can eventually result in a suprachoroidal hemorrhage at the time of surgery or maybe postoperatively. Now, most patients understand that whatever surgical procedure you do is going to be a visual panacea, and they're going to improve their visual acuity post-surgery. So it's very important for you to counsel your patient when you are taking them up for trabeculectomy that for some time your vision may decline. It's definitely not going to improve as you would expect post a cataract surgery, and you need to explain to them that in post-operative period, when you give them atropine for the success of the surgery, that it's going to result in a drop of vision, and some patients who have hypotony may have a resultant drop of the vision till the time the hypotony is addressed. So some amount of post-op astigmatism can also result in change in their glasses once the post-surgical phase is settled. Now, we also need to find out the risks of surgical failure in these patients and step up our intraoperative planning for these patients. So patients who are going to be operated for a TRAB at a younger age, those who have inflammatory glaucomas like a uveitic or a neovascular glaucoma, those who have had a previously failed glaucoma surgery with compromised conjunctival mobility, or those who have an extensively scarred cornea from a prior surgery, or those who are aphakics or pseudophakics may have a compromised outcome. So you may want to modulate your MMC or 5-fluorouracil regime in these patients to prevent early postoperative failure in these patients. And sometimes you may need to give preoperative steroids for them so that the conjunctiva becomes less aggressive postoperatively. Now, a thorough examination is very, very important. You may miss out an NVI or an NVD or an NVE, and that can, be very disastrous. So looking at the disc, at the iris, is really, really essential, especially if your patients are diabetic. Now, coexistent cataract is quite common in patients who are elderly because at that age, cataract and glaucoma coexist. So for you to know the best corrected visual acuity is important, because many a times after atropinization, the patient will just come and say that they've had a major drop in the vision and they would not be really satisfied. Unless until you have a documented visual acuity, you will not be able to explain to them that, see, this is just the drop is because of the drug and not anything major. How much of the decline in the vision is due to cataract versus glaucoma is something that you need to understand yourself to plan either a phased surgery or a combined glaucoma with cataract surgery. Gonioscopy is very important preoperatively as well as postoperatively, and if patient has had angle recession, you need to understand and tell them that the outcome may not be as expected. For a chronic angle closure glaucoma patient, you have to be watchful for malignant glaucoma in the postoperative period. Look for any iridodonesis or phacodonesis or neovascularization. Do a thorough slit lamp examination a day or a few days prior to the surgery, even if you have seen the patient well before in advance. So things like pseudoexfoliation, posterior synechiae, the amount of pupillary dilatation, all these have to be noted in your pre-op sheet. How damaged is the optic nerve? Is there any coexistent macular or retinal pathology? Because they may limit the visual potential is something that you need to note. Plan wisely. If there is mild to moderate glaucoma with cataract, you can do a sequential surgery, and nowadays you can do a phaco with MIGS, and the easiest is phaco with bangs. It's something that you can do right at the same sitting. For advanced glaucoma cases with coexistent cataract, a sequential phaco followed by trab versus combined, and if you're considering a combined surgery, a single site versus two site phacotrap can be considered. Now there's no quick fix for informed consent. I've seen many residents over the years just telling the patient, yeah, sign kar do, and all that. They don't really explain what is written in the consent paper. The patient's expectations have to be very realistic when we are dealing with an advanced glaucoma. So getting a 10-2 test done or a macular test done in patients with visual field defects closer to fixation should be done mandatorily prior to the surgery, so you can explain the risk of wipeout. Even if it's minimal, the patient should have a reasonable expectation as well as knowledge of the same. Response of the contralateral eye prior to a prior filtering surgery can help you prepare better if the other eye has had a choroidal detachment or a malignant glaucoma when they had undergone a trabeculectomy is something for which you should become cautious and take corrective measures right in the beginning. As regards the preoperative preparation, pilocarpine should be stopped at least a day prior to the surgery. Pilocarpine is something that is pro-inflammatory and it breaks down the blood aqueous barrier. Some people like to stop prostaglandins 2 to 3 weeks prior to surgery, especially if the patient has significant ocular surface disorder. If not, you may continue with it, but that's the calling of an individual surgeon. But you need to really focus on the ocular surface disease, and inflamed ocular surface is going to compromise the success of the trabeculectomy. Patients who have been on multiple medications, 3 or 4 drugs, even if the drug says that it is preservative free, it has a certain amount of buffers and other things that keep it in a steady state for a month. So all these multiple incipients and buffers lead to chronic inflammation. So in cases you have an eye which is inflamed, topical steroids can be started a week prior to the surgery. So ocular surface disease is something that you really need to look out for. Ma'am has already talked about it. Some systemic medications, and especially if the patients are on oral anticoagulants, need to be noted. It's a wise idea to consult with a physician, because we as ophthalmologists may not be the correct people, and in most of the times, most physicians or wherever you are having a pre-anesthetic checkup, they stop these drugs a week prior to the surgery to minimize a bleeding diastasis. Many now operate patients with INRs less than 3, and in cases that the drug cannot be stopped altogether, heparin bridging is preferable. So for that you need to be consulting a physician simultaneously. Nowadays, with the newer drugs, newer oral hypoglycemic drugs like dapagliflozin, it is imperative that we stop these drugs 3 days prior to surgery. Otherwise, you may end up in a euglycemic ketoacidosis and you'll have a problem at hand postoperatively. Preoperative intraocular pressure levels are also important. If they are more than 30, IV mannitol needs to be given preoperatively. As a rule, I give pre-op mannitol in all my patients because this prevents sudden ocular decompression and can prevent decompression retinopathy. Peribulbar anesthesia is something that makes the surgeon as well as the patient comfortable. Additional lid block in patients with blepharospasm can also help. Consider GA if the patient is claustrophobic with the prior surgical experience or is uncooperative or challenged. So the preoperative checklist includes a preoperative medication history, other preoperative assessment, which includes ocular as well as non-ocular aspects. The surgical part of it focuses on the consent and the type of anesthesia, and all this should be discussed with the patient. Just a couple of slides regarding what to see after trabeculectomy. Always grade your blebs. Don't just look at the pressure. Don't just comment on whether the AC is formed or not. The main determinant of the long-term surgical success is the healing process that is happening in the bleb area. So you are not going to remember how the bleb was on day 1 or day 10. So it's very important for you to document it, grade it to recognize an impending failure in time, so that you can intervene in time and salvage these blebs. And for this, you need to have a standardized grading system. You can use a classification system like IBAGS, which looks at the height of the bleb, the horizontal and the vertical extent of the bleb, the vascularity, and the Siedel's nature of this. So you can go through this grading system and try documenting it. Remember that these are the signs of a failing bleb. If there is an unacceptably high intraocular pressure, if there is corkscrewing of vessels, as we can see here, if there is a very high domed appearance of the bleb, or the bleb is getting encapsulated with severe angry looking conjunctival vessels, or if it is entirely flat with subconjunctival fibrosis, you need to intervene in time if you want this bleb to survive. Now, many studies have shown that it's all because of the cytokine storm that is building up in the first 3 to 4 weeks. So you can add either preoperatively oral ibuprofen, or sometimes you can give an indomethacin type of an agent from week 3 to week 6 to tide over this period, so that you don't end up with tenant cysts or encapsulated blebs. The last slide, I'm not going to go in details, just try and categorize your patients if they end up with the post-trap complications, whether they have a low IOP, and if there is low IOP, if they have a low bleb, or are we dealing with an overfiltering bleb, or if they have post-operatively high IOP with encapsulated blebs, or with low blebs. If they have low blebs, look for the anterior chamber depth, and definitely look for the peripheral and central things. So you have to go separately into a post-trap complications, but look out for all these factors so that you are able to figure out the problem and address it properly. And remember that no notice is taken of a little evil, but when it strikes the eye. So here we have a typical white on red blebitis appearance appearing. So you really need to lift up the lid and look at the blebs properly, look at the vasculature, grade them and document them, because there is nothing which is innocuous in the early post-operative period. So thank you.
Thank you, Dr. Parul, for a wonderful presentation. As we are already short of time, so the talk on implant will be taken up in the last session if time permits. And before we wind up this session, I will just like to reiterate certain highlights of this session. Regarding medical management, we all know that medical management is the initial line of treatment in most of the patients. But before you start medical therapy, you have to be very, very sure of your diagnosis. Never start medical therapy if you are in doubt of your diagnosis. And once you have decided to start medical therapy, set a target pressure. Start with monotherapy. If you are not able to control the pressure, only then add another drug. And fixed dose combination, definitely they have to be given, but sometimes we see that multiple fixed dose combination and both combination containing similar drugs, or timolol sometimes in both the combination. It's a quite serious thing to give timolol in multiple fixed dose combination. Timolol is not a safe drug, lot of side effects. We have to be very careful. We have to know the contents of fixed dose combination. If it's containing timolol, other fixed dose combination should not be having timolol. And if patient is having side effects of multiple drugs and his quality of life is affected, never hesitate in planning surgery. Then trabeculectomy is the next step. But remember, trabeculectomy is not cataract surgery. It needs lot of babysitting. So in the post-operative period, you can't leave patient just as such. You have to do close monitoring. Whenever you feel that IOP is rising, try to decrease the pressure either by massage. If you have put a releasable suture, release the suture, or do the laser suture lysis. And if bleb is failing, don't hesitate in giving 5-fluorouracil additionally. So that is in early post-operative period. But after window of 2 weeks, then chances of saving or salvaging the bleb is less. So for initial 2 weeks, be very attentive. So whenever you find any sign of failing bleb, intervene. So that will increase the success rate of your surgery. So with this, I thank you, Dr. Sushmita, Dr. Parul, for their talks, and we shift to next session on retina and uvea. So I will request Dr. Rima to kindly come to the dais, and Dr. Gaurav, please come for the first talk, and I will request Dr. Simar to come on the dais. As Dr. Rajiv couldn't come, Dr. Sabina is also not here.